This patient with prior myopic LASIK in both eyes presented with defective vision in the right eye. This is the timeline of his past treatment. As you can see here, he was on oral, topical and inhalational steroids at the time of presentation. Clinical examination was unremarkable. He had myopic refraction and high intraocular pressure without any other findings. To rule out post-LASIK regression, a pentacam was done and the primary examination did not reveal any ectasia. No previous pre-LASIK topography was available. He was hence prescribed glasses for the refractive error. Since he was on steroids in various routes, a probable steroid-induced ocular hypertension was suspected and anti-glaucoma medications, both oral and topical, were added to bring down his IOP. On subsequent follow-up, nothing changed. His myopic refraction and high IOP continued to persist. IOP by applanation was still high, but eye care readings were higher. On careful examination, we could pick up peripheral corneal edema. It was actually missed in undilated and picked up in the dilated state against retroillumination. Now, we started doubting ourselves and re-looked at the images. On closer examination, we noticed high central corneal thickness. We did an anterior segment OCT which showed an empty space in the corneal stroma, suggestive of a fluid cleft, thus nailing the diagnosis of interfacefluid syndrome. We stopped all the steroids and continued the anti-glaucoma medication. After discontinuing the steroids, patient had a dramatic visual improvement. Note the IOP by Goldman applanation tonometer and eye care tonometer. A repeat imaging revealed reduced central corneal thickness and the ASOCT also showed disappearance of the fluid cleft. As the cornea cleared, we could appreciate a keratic precipitate too. This patient probably had Posner-Schlossman syndrome, for which he was receiving oral and topical steroids. He had been having recurrent redness over 3 months and the complete uveitis workup turned out negative. Adding further to the insult was the concurrent use of steroid inhalers. This could have tipped the balance, causing high IOP and interfacefluid syndrome. We continued the anti-glaucoma medications and added topical NSAIDs for now. With the fluid gone, both of us were happy and all is well now. Now, let us understand this intriguing condition better. Throughout the literature, multiple authors have given different names to this condition, but for convenience, we will use the term IFS. This condition is characterized by fluid accumulation in the potential space in corneal stroma following any lamellar surgery. Dawson and colleagues proposed a classification system for IFS. High IOP or endothelial dysfunction leads to fluid accumulation in the corneal stroma, which can be appreciated as an optically empty space in the slit lamp. Any lamellar corneal procedure can cause this condition, though it is widely reported after LASIK. Contrary to common belief, post-LASIK corneal healing is incomplete, predisposing to this condition. Surprisingly, the presentation can be variable, with reports of IFS even 19 years after LASIK. So, history taking is critical, as many patients may even have forgotten having had this procedure. It is crucial we understand this is a vision-threatening complication. Characterized by painless loss of vision, it becomes critical to identify this early to prevent blindness in young patients. The artificially low IOP measured after refractive procedures is a major drawback, as this delays the diagnosis. The Imbert-Fick principle of Goldman applanation tonometer fails in these eyes due to altered corneal biomechanics. To be aware of this is critical in avoiding glaucoma progression due to continued iatrogenic steroids. Though Goldmann applanation tonometry is the gold standard, it is important to understand the limitations of this tonometer to check peripheral IOP and its poor reliability after refractive surgery. One should understand the consequences of applanating a fluid-filled sponge. So, what to do? Simple. Choose your weapon wisely and use tonometers which can check peripheral corneal IOP. Higher peripheral corneal IOP is a definite clue to diagnosis. The issue with IFS does not end here. IFS can be mistaken as diffuse lamellar keratitis. These two disorders have opposite treatment strategies and should not be confused. DLK is characterized by a wave of granular infiltrating cells, giving it the nickname Sands of Sahara. Can we confuse DLK and IFS? Yes. This series presents glaucoma due to iatrogenic steroids after a misdiagnosis of DLK in all IFS patients. IFS should be considered without pumping steroids continually. So, how do we pick up IFS easily? Look for a sudden myopic shift, an increase in central corneal thickness, and a steepening in corneal topography. These changes, when compared with preoperative values, can help in identifying the disease early on. ASOCT is a must in these eyes, and two tonometers should be used to cross-check the IOP at the central as well as peripheral cornea. Our goal here is to reduce IOP to prevent fluid accumulation in the corneal stroma. Topical and oral anti-glaucoma medications along with cessation of steroids helps. IFS is rare, but the eye does not see what the mind does not know. Know the pathology, the defects in our tools, and the alternative ways of addressing them. Steroid is a double-edged sword. Use only when needed.